Hello and welcome to Addis Matters, our show on Ethiopian current affairs with me, Begna Simesso. This is part of our COVID special series. As coronavirus continues to affect the world, we are analyzing all aspects of the virus, from the science of the pandemic to its political, economic, social consequences, with rigor and global perspective. On this edition, we shall look into the medical response given to the pandemic in Ethiopia. I have two guests, young doctors, to help us understand the matter. Dr Chala Fekadu is Assistant Professor of Medicine and Internist and Cardiologist at Addis Ababa University's Black Line Specialized Hospital. And Dr Lina Tamrat is Assistant Professor in Anesthesiology and Critical Care Specialist at Yekatit Asrolet Hospital Medical College. Welcome to the show and thank you for your time, views and insights. You are frontline workers and thank you for your time. The novel coronavirus was discovered in a patient in Wuhan, China in November 2019. Since then, it has reached all corners of the globe, and to date, millions of people have been affected by it, and hundreds of thousands of people lost their lives. The virus entered Ethiopia through a Japanese who traveled from Burkina Faso in March 2020. Since then, with very limited testing capacity in the country, the number is steadily increasing, and a few people have lost their lives. A number of measures have been taken by the government. A state of emergency was declared. Schools, religious institutions such as churches, mosques, as well as social service institutions like courts are closed. Transportation services are ordered to operate in half capacity to minimize social and physical interactions, just to name a few. In a medical response, a number of sites were converted to serve as quarantine sites. Schools, hotels, meeting halls were converted into hospitals, more than 100 in Addis alone. Dr. Chala, let me start with you. Was that enough? How do you rate the medical response given by the Ethiopian government, health institution, as well as the public in general to the pandemic? What's missing in our response mechanism?
Okay, so to see the response towards this huge pandemic in Ethiopia, to start with the government, earlier on at the beginning of the pandemic, before the virus was introduced into our country, our preventive strategy to prevent the entry of the virus was quite late. The Ethiopian airline, which is the main gateway for travel in Africa for countries that are heavily affected by the virus, like China, Italy, and other European countries, was not restricted earlier on. So we don't know the dynamics of the virus. During the initial period, people were not quarantined. They were freely allowed, even though they are coming from those countries who are heavily affected. So we don't know what happened to those people. We know only of this Japanese patient who came to the country. So with regards to the population spread, we don't know what's happening. Even later on, we see patients who are dying and who are later on being diagnosed as having COVID-19. So, but later on, we have seen different phases of response by the government. Several institutions have had restrictions to prevent the transmission among the population. It was quite strict restriction during the initial phase, but later on, it was quite slow, and we didn't define the pattern of the disease in our country. So we see later on, some institutions are reluctant, the workers were coming back to their workplace, the crowding and anything, everything started to be like nothing is going to happen. So the political commitment in our country from the government side was quite late, but in the later phase when the community spread becomes inevitable, so now I see it's quite a fair response by the government. When it comes to the public, so initially it is a failed response earlier on, but later on the later phase, when we are quite late on it, now it is a better response as compared to the previous phase of the disease progression. When it comes to the public response, so the population was quite unaware in the earlier phase again. So if you remember the Easter market, people were not masked by a face mask, and there were very heavily overcrowded marketplaces, even though the religious institutions were restricted by the time of Easter celebration. So probably we have seen the impact of that later on. That was the reason why we see here and there the community outbreaks in the population. In the health institutions, if you see the response to coronavirus, as you have clearly mentioned, several institutions were committed as isolation centers and treatment centers for COVID-19. So that is quite a good response for the number of patients that we are having to date. Those institutions have got a capacity, but when you see the health sector in our country, it is one of the neglected sectors. The healthcare in our country is going far behind the developed world. So we are decades and decades behind the world. So the quality of care, I don't want to go into the details, but the medical response with regards to the control in the care of the patients, if we compare it with what is happening in the better side of the world, we are still far behind them.
The capacity of our health system is quite limited. So basically you're saying the timely response is not good enough. Yes. Do you share that view, Dr. Lina?
Partly.
Partly,
yeah.
All right.
Because I was quite surprised by the amount of attention given to COVID from our political leaders, from the Ministry of Health and the like, and I was very appreciating it. But the thing is, this is what I see in every move. We lack proactivity. That means being able to anticipate things before they actually happen. So we started kind of acting and preparing for COVID when we get the first patient in our country. And I'm saying this like in the general terms. There were some preparation ahead of time, but they were not enough. Okay. It was obvious that we're going to have patients. So it was better if we had scaled up our surge capacity, stocking up drugs and mechanical ventilators and other medical equipments, but those didn't happen. The response is like cause and effect. When you have patients, a large number of patients, you prepare the mechanical ventilators. That was how it was. Now, we all know every hospital, even now, we all know every hospital in Addis or in the country will be receiving COVID patients sometime soon. But we're not preparing those hospitals. Like, we're not preparing the ICU, we're not preparing the healthcare workers on how to deal with these situations. We're just casting our fears or our anticipations on the isolation centers, on the designated COVID centers. And that's not wise, because we are going to face it, and we're not doing much about it.
Okay, that's very interesting. I think lots of buildings have been converted into hospitals, but one of my questions was actually, probably I will raise it later, the HR capacity to deal with, the forecasted millions or hundreds of thousands of patients to come into the health centers. But I want to start with each step one by one, from testing, isolating, contact tracing, quarantining, caring, and treating. Let's focus on testing, for instance. I think our testing capacity is very limited. The surprise that came a few days ago in Debra Burhan, they did a random test in a bus stop, and 36 people were diagnosed, and of them, 16 had the pandemic, the virus in their body. what should be done to improve our testing capacity? This is probably a very general question, but there must be ways. I mean, there are other innovative mechanisms to try to find out what's going on. Do you suggest anything, Dr. Lina?
So the good example is Senegal.
Right.
The Senegalese, they had confirmed cases from Africa earlier on, but they started preparing this almost immediately. They started manufacturing mechanical ventilators, they started preparing to produce test kits, and they were very proactive about it. So this is what the Philippines and the Koreans were doing compared to the US. So we have a lot to learn from the Senegalese, being proactive about things, anticipating that they would actually come to our setup and then preparing for that. So when we come to our setup, when we come to actually upgrading our testing capacity, we have lots of skilled professionals, and we have to make them equipped. They have to go to Senegal, they have to learn how they do it, the African way, and they have to come back and then replicate that. And I believe there's a lot to share from the Senegalese.
Okay. I think, they are quite experienced in dealing with previous outbreaks like Ebola and other regular diseases, and I think they are well equipped, to deal with this problem. Dr. Chala, do you have anything to add on this?
So the type of test that we are doing in our country is the PCR test, which takes quite a considerable amount of time before the results are released, and this will allow patient contact transmissions between patients and transmission to health professionals as well as community spread. Until the result comes, most of people who give sample, they continue to be in close contact with other peoples. So we have to start doing the antibody tests, which will make our results ready within matters of minutes and hours. So with antibody test, you don't need to transport samples to other centers of laboratory with larger laboratory. So it can be done by trained nurses and local lab technicians. So the results would be available very soon. It's like the HIV test that we are used to it. So we have to start performing these tests. It will allow us to do large-scale testing and define the pattern of the disease, the true pattern of the disease in the society, which we don't know yet.
And to add on that, we have to be smart about it. We live in the third world country, let alone Ethiopia, other countries, the Westerns are struggling with this issue. So we have to be smart about it. We have to be selective. We have to test people who are prone, and those who are supposed to be highly exposed, or those who are supposed to be there, who are presumed to be super spreaders, like healthcare workers. Those should get these populations should get priority in testing, because when you test a healthcare worker, you are actually saving other prone individuals that the healthcare worker will probably treat later on. And not only that, we have like HIV patients, we have like tuberculosis patients, elderly population, those with comorbidities. If they actually get the disease, will suffer a lot. So while trying to catch the disease early, this actually testing those patients and giving priority for those patients will actually help in their morbidity and mortality. So being smart about it and actually being selective in who to test, which population should come first, should be really thought of.
This antibody test that you mentioned, Dr. Chala, it's like an indirect indication of the situation, isn't it? Like it doesn't clearly tell whether a person has COVID-19 virus or not.
So basically, antibody test is immune response against the virus. So it means that clearly if someone has got immune response against the virus, the person is infected. So at least it will help us triage the size of the impact of the infection and how huge the burden is. So it will not take time. And if you declare someone is negative, that's a good news. So you will allow them.
Will it create a sense of false safety?
So with these tests, there are a number of kits. They are tested. The sensitivity and specificity stuff. Sensitivity means how much, the power of detecting all the positive cases, and specificity of antibody test means how much specific that test is for the specified virus. So we have quite good sensitive and specific antibody tests that are being used in other parts of the world.
The bed capacity is increasing. Lots of venues are converted into quarantine sites. But please comment on the human resource needs. Do we have enough trained professionals to deal with this problem in this country?
No. We
That's
don't
quite
have.
straight.
Obvious,
Yeah.
quite obvious. We don't have the trained manpower to handle this disease. Specifically, there is an unknown component to this disease that you will need skilled professionals who can actually anticipate and actually figure out how this patient will progress from one stage to another. You need those kinds of professionals who are actually trained with or who had experience with this kind of infectious disease, and we have quite few of them. That being said, there are lots of venues which are converted to more of a treatment center, but those venues, they lack not only the manpower, but the medical equipment, the medical supplies, the drug supplies, the consumables. Those are not there at the moment. But I think the purpose of these venues is to treat, not actually to treat, but to be used as a quarantine center, to isolate those patients so that they don't actually go around and spread the infection. And these centers are not meant to treat those patients. They're meant to just isolate them. So when you think about that, okay, that could serve the purpose. But if we're thinking about actually treating patients, you have to focus again on the hospitals, because we can't afford to build hospitals. We have to reinforce what we already have.
Dr. Chala, what's the treatment like? I mean, let's assume someone gets infected with it and gets into a quarantine site or a hospital. What kind of support and treatment do they get? Is it just simply to isolate them from the community, or is there a service to boost the immunity probably?
So the treatment demand of patients with COVID-19 has basically the disease is heterogeneous. So we have people who have no symptom at all, and which are the majority, and almost close to 80% of the patients have mild symptom to no symptom. And we have 15% who have moderate, and later on 5% of them are having severe disease, so who are requiring high level of medical care, which needs mechanical support, circulatory support. So they need high level of care. The main reason, as Dr. Lina was mentioning, those isolation centers are quite enough for them, because they will recover on their own. For patients with severe disease, but we need significant level of medical support, which we are lacking in Ethiopia. We don't have critical care specialists. So there is, to my knowledge, there is only first batch of critical care fellowship in Black Lion Hospital. So we have a scarcity of critical care specialists. In our ICUs, if you ask me about the ICUs, we have very few and limited number of mechanical ventilators, and the number of our ICU beds are quite limited. So the type of care that we give to the patient depends on the complications they have developed. So mainly, this time, even in the other side of the world, there are only very few medications that have shown promise. So to mention one, there was a recent publication on BBC. The British physicians have tested a drug called dexamethasone on patients who are on mechanical ventilator, and actually that's the first medication to reduce mortality in patients requiring mechanical ventilation and severe form of the disease. So mainly the treatment to date is towards supporting the patient in treating the complications, but we don't have treatment that is directly targeting the virus and that has showed response. There are some antiviral medications that have shown slight benefit, but still they are not meaningful when it comes to treating a large number of patients. So mainly the treatment is supportive treatment depending on the kind of complication the patient develops.
Okay. So those supportive treatments, are intended to increase the immunity of the person, isn't it?
Basically, if you ask me the immunity, the drug I told you, dexamethasone, like our immunity is again the problem in corona. The immune response against the virus damages our body.
Okay.
So the respiratory failure, the organ failures result from exaggerated immune response. So what this dexamethasone is an anti-inflammatory drug. So it tries to suppress the immunity rather. So we are preventing damage that results from our exaggerated immune response. So as the time goes, we might have some time to know better about the disease. As it is new, there are a number of ongoing medical research. So we expect a lot from the ongoing trials. But boosting immunity is not the main
It's
concept.
not the main.
Yes.
Yeah. Okay. I've seen some, papers circulating on social media. You can't trust what's circulating on social media, but that's really helpful. Dr. Lina, you are an ICU specialist. I better call you this than anesthesiologist. Once patients pass the stage of getting immunity boosting this service, and once they get into the intensive care unit, what is it like for patients?
Wow, it's very difficult. This disease is unlike any other disease we have seen. These patients, I have spent some time in Eka Kotabe, and these patients, they present with shortness of breath. They're unable to breathe. Their lungs are failing. So you need to put them on mechanical ventilators that will actually replace the function of the lung. But what you see is the oxygen level in their blood drops significantly. When a normal patient's oxygen blood drops significantly, you would see the patient being comatose, confused, and these patients have a clear mindset. They don't want to be put on mechanical ventilators. They're aware of their environment. And so most patients don't want to be on mechanical ventilators, especially those who actually know about mechanical ventilators or who have actually seen the patient on the next bed pass away after being on mechanical ventilator. Mechanical ventilators actually help the lungs, but on the other side, they damage the lungs. It's a balance between the two. So it doesn't look good. Once they're put on mechanical ventilator, those patients who are elderly, those patients who have comorbidities, they don't survive most of the time. And in our setup particularly, because of the nature of the disease actually have variety of presentations. Some may have cardiac problems, heart attacks, some may have kidney failure, some may have neurologic, or they will present with stroke, or half of the body being paralyzed. There are different presentations. And in our ICU, mainly most of the ICU care that we actually give is supporting the heart and the lungs. And all of these presentations, they require, all of these disease entities, they require a comprehensive way of actually tackling the disease. And in order for us to do that, we need different investigations, laboratory, different drugs. And we don't have that in most of the ICUs in our setup. And it's quite difficult. In some of the ICUs, we don't even have chest X-ray, portable chest X-ray. Imagine taking care of a patient who has a sick lung and being blind. You don't know what's happening to the lung. We are unable to transport patients from one place to another, because in order for you to transport that ICU patient, you need a sterile environment. You don't need to expose other people. ICU is a place where you have lots of viral particles just suspended because of the pressure in the room. So it's getting quite difficult.
Wow. It's an ugly environment.
Yeah.
You've developed, the number of ventilation machines that we have in this country are very few hundred, actually, I heard. I've seen on your page, you guys have turned a machine that serves one patient to serve 4 patients?
Yeah. That's actually...
Tell us about it.
we have very limited number of mechanical ventilators, as you have rightly said. So what we were trying to do is just see what the rest of the world was doing. And in the US and in Italy, because of the large number of patients that they were having, they were changing one mechanical ventilator. It's just like dividing the outlets of the mechanical ventilator into 4 parts so that 4 patients can be served with it. But the thing is, the setting for one patient may not be good for the other patient. So there is a process of matching the patients, which will need lots of investigation, lots of manpower, and then actually doing it. And nowadays, patients, it's recommended, like, since there's a lot of aspects of the disease not known yet, what we can do, being in Ethiopia, is learn from the mistakes of the New Yorkers in Italy. So what they're saying, what they're advising us is not to put every patient on mechanical ventilator, not to put the first 50 patients who need mechanical ventilator on mechanical ventilator, to wait it out, look for other options, proning the patients. And this will actually help, and using alternative methods of delivering oxygen, and those are helping them out. So nowadays we need mechanical ventilators, but we're not in a rush to put patients on mechanical ventilator, because once they're on the mechanical ventilator, the survival drops. Yeah.
Dr. Chala, let's get out of, I feel like I'm in ICU unit now. Let's get out of the hospital setup and let's talk about the perception about the virus. I feel like there is a polarized perception about the virus. In one hand, people consider it like a simple flu. It can come and goes like a seasonal cold. But on the other hand, there is a real fear about getting infected with the virus. We can, refer to the 25-year-old girl or a young lady who committed suicide in Arba Minch just because she was suspected of having it. Fortunately, she didn't have the virus, but she feared it to that extent, and she committed suicide even before getting the result. We are also hearing a stigma about, patients being excluded from social circles. Help us get a balanced understanding of the virus. How is it like? What is COVID-19?
Basically, both extremes are not proper knowledge about the virus. So I'm not a fan of those who disregard it, and the other extreme who fear it quite extensively is not also proper. So we need to have a proper understanding. So the media's various news outlets are continuously updating us. So people should understand acquiring COVID doesn't mean the end of the game. Like, it is not like majority of people who acquire COVID will recover. So on the other extreme, it is not a simple flu. There are people who are developing severe form of the disease that is leading into death. So mostly, if you see the part of the population that are disregarding it, the youngsters consider it as a simple flu and they don't care and they don't take care of themselves. So we have seen young patients developing severe disease and they are dying of it. On the other extreme, the elderly are the most stressed part of the population. We know the elderly are at risk of developing severe form of the disease, but we have seen on several news outlets patients in their hundreds recovering from ICU, being discharged, having recovered from COVID-19. So the disease is having a heterogeneous manifestations, but a single individual have the same chance of having milder form, moderate form, or severe form of the disease. Nobody is immune. Everybody can acquire. Being young, statistically speaking, majority of them have mild disease, but there is still a chance that we can develop severe disease. So we need to have a balanced understanding. So we need to follow the media, the recommendations from Ministry of Health, recommendations from international institutions like WHO and CDC, and we need to have the proper understanding about the virus.
Dr. Lina, do you like to add anything on this?
This disease actually it's a very challenge for the immune response. We need a smart immune response, not overactive, not underactive. So a young, fit individual who exercises well and eats well could have the same risk as an elderly person because his immune system is overactive. You never know. So all of us have the same risk. All of us could end up really suffering from the disease or even might be dying from it, but there is also a good chance that you'll actually have the infection and then recover from it, even be asymptomatic, not showing any symptoms at all.
I think the conflicting advices are coming from the health sector as well. In my view, let's take hydrochloroquine, for example. President Donald Trump endorsed it, WHO advised against it, and then WHO retracted its opposition. Face masks, the same. There was like a phase. Initially, they were saying it's not absolutely necessary. Then the advice came, or the asymptomatic transmitting the virus. Initially, WHO strongly cautioned people with the virus, but without symptom can actually pass it on to others. But recently, Dr. Navarro of WHO said it's rare, actually. Does this entail disjointed, uncoordinated, unscientific response to the problem at global level? What's going on?
I don't think it is the uncoordination. Rather, it is the undefined nature of the virus. We know very little about the virus dynamics. So we are seeing a number of publications. Most of them are not peer-reviewed. They are preprints that are being published. If you ask me the issue about the chloroquine that was retracted, which was retracted by WHO, it was based on a data which was published on Lancet, in which the source of which is not clearly known. So the main reason WHO, it is a huge data from 5 continents. So that database claims that they have included 169 hospitals from all over the world, including Africa. And there are a lot of questions about that publication. By the time Africa was not having any ICU cases from Africa were reported on that data. So the owner of the database was not open for other investigators to see the data. And the main author was a professor from Harvard University. So he just got the database from the co-author and he was involved in the writing, but he doesn't know the details. Later on, he confessed that he doesn't know the database. That was the reason. So it looks like it is a fake data. That's why the recommendation, which says chloroquine is associated with high mortality. So that's why WHO trusted that publication. That's why many trials on chloroquine that were ongoing and that were funded by WHO were discontinued. So this time, with regards to chloroquine, we have latest data which was published yesterday in New England Medical Journal. There is no increased mortality. There is no also improvement in mortality with regards to chloroquine administration in patients with COVID-19. So we need more time in order to define the disease, treatment response, all those data that are being published. As I initially said, I want to emphasize that they are not peer-reviewed. There is a big hunger of data in the scientific society. So everybody is voracious in trying to define what the disease is. So I don't blame those international organizations for being disorganized. It's because of the changing behavior of the disease.
It's early days,
yeah,
and we know very little about it. Let's talk about the future then, the projections. I mean, I hate numbers since COVID came. Numbers have become so elusive. I mean, be it infection rate, today you hear thousands and next day it jumps up like that. Especially when it comes to future projections, it's really scary. There are a number of scary mathematical models coming out. Let's focus on in Ethiopia, for instance. Initial projection for Ethiopia, which came out back in late March, was up to 26 million people could get infected. 8 million could die. Recent projection has gone down considerably, up to 8 million infections and up to 400,000 days. Another modest prediction forecasted 26,000 days. Forget the numbers, but tell us what to expect in the future. I mean, it doesn't have necessarily to be in numbers. What should we expect, especially in the rainy season? It used to be associated with the seasonal flu as well. What shall we do in due course to get ourselves and our loved ones safe?
So basically, I'm not also a big fan of these predictive models. So predicting the pattern of a disease we know a little about is something very difficult. And the population dynamics in Ethiopia is quite different from the population in the Western society. As you know, the lifestyle of our population, most of our people are poor community. They share rooms, and there are people who share the same room as a bedroom and salon and every activity with large family size. So we don't expect the same population dynamics like that happens in the other part of the world. So we have overcrowded housing in many of the cities. So we expect even continuous spread in the community in the coming days, unless you cannot declare complete lockdown in Ethiopia because it has significant economic burden on people who are daily laborers. They have to live, they have to eat in order to continue to live. So it is very difficult thing to say, but in my opinion, it will continue to spread in the population. In my view, the main thing that would prevent spread is when the vaccine comes into the picture, we can prevent spread in the community. Otherwise, with the existing community lifestyle of our people, economic status of our country, we will have a difficulty in combating community spread.
What shall we expect?
I would have to agree with Dr. Chala because there's a lot that we don't know about it. But the thing that I would expect that would be a challenge for us is the issue regarding the deaths due to COVID. The way we actually record the deaths is very confusing because any patient who tested positive for corona could die from any other number of illnesses, including accidents. The WHO has not updated the definition of deaths due to COVID. So we have to actually try to delineate and have a red line. This patient died from COVID, this patient had COVID but did die from something else. We need to have that settled, one thing. The other thing is regarding the other diseases that we tend to ignore. People could actually die of diabetes, HIV, tuberculosis and other diseases, including laboring mothers and pregnant ladies. And these disease burdens tend to be ignored. And because of that, we could have exaggerated number of deaths. Yeah, so we have to work on that. Other than that, I know that COVID will be here for a while, is here to stay. So we have to actually find the balance of treating the two entities, COVID and non-COVID.
Okay. So we should expect that it will be around for a while and we should be ready to face it. We are approaching the end. I want to end with a positive vibe. You mentioned the African resilience earlier. Over the years, we have faced various health calamities, from cholera to malaria, HIV and Ebola. We know how to live with these things. And you are also saying this virus could stay with us for a while. We must have learned how to deal with such difficult situations. What should we apply on COVID-19 that we've learned on other diseases? Dr. Chala.
So I think the benefit we get out of COVID is that our healthcare sector that has been, I will say, ignored for quite a lot of time is getting attention. So like everybody goes out of Ethiopia in order to get advanced treatment. This time we need to bring the best treatment. We need to upgrade our ICU care. So the field of medicine that will benefit huge aspects out of it is the critical care medicine in Ethiopia. So we used to have a small number of patients who are getting ICU, and the rest of them who require ICU were dying. So by the time COVID goes away, so we will have a large number of mechanical ventilators. We have physicians who are experienced in delivering critical care, in the ICU beds will be kept expanded. So I think that we learn out of COVID.
Blessing in disguise, sort of. Yeah? In conclusion, I think prevention is the best option, the safest, and the cheapest as well. Both of you give us some piece of advice on prevention. Dr. Lina, let me start with you.
I would start, if I had an advice, only one advice to give to my fellow citizens, it would be to spend as little time as possible, especially for physicians, together. Because physicians may acquire the infection from the community or within their workplace, but transmitting that to a fellow physician the risk is exponentially high. That fellow physician would transmit it to the community, and on top of that to other patients, vulnerable patients. So it could be drinking coffee or tea or having lunch together. These things have to be sorted out as early as possible, because we can't afford to lose lots of healthcare providers because of this. So this is one tip.
Yeah. Let's focus on preventing the healthcare workers. Dr. Chala?
I don't have anything to add. By this time we know the mechanisms how to prevent, and we have a number of media outlets advising us on prevention of COVID-19. But what I want to advise our fellow citizens is that we have to be consistent until we get rid of this COVID-19, or until we get effective vaccine. We have to continue those preventive lifestyles throughout our every activities. So we should not visit our elderly family members, because they are the most vulnerable part of the community. And we have to stay away from each other. The Ethiopian community is known for its social interactions. So I know this time everybody understands what COVID is. So we have to be consistent in preventing COVID-19 until we get rid of it.
Thank you. We have come to an end. Thank you for watching. Thank you both for your contribution, Dr. Chala Fekadu and Dr. Lina Tamrat. Next time, we'll be back with another topics and another guests. Until then, goodbye from me, Begna Simesso, and the team at Addis Matters.